Assalamu alaikum. Good evening, everyone. It's Dr. Sadaf here. Thank you all the respected participants to join in. Our today's guest speaker is Dr. Humza Hassun. He is a consultant orofacial pain medicine at Pakistan Kidney and Liver Institute at and Research Center, PKLI and Smile Center, Lahore. He is primarily a dental surgeon, and he has completed his clinical fellowship in orofacial pain from University of Medicine and Dentistry, New Jersey, United States of America. He is also Masters of Dental Science in Orofacial Pain, and he has also earned his fellowship in general dentistry from USA. So thank you, Dr. Hamza, for joining us. You can start the presentation now. We'll be taking the questions at the end of this session. Thank you, Dr. Hamza, for joining us. Over to you,
Uh,
Dr. Hamza.
Thank you, Dr. Sadaf. Can you hear me, please?
Yes, sir, we can clearly hear you and we can see your screen too.
Okay, all right. Okay, so Assalamu alaikum, everyone. First, I would like to thank the Call Society for giving me an opportunity to present this presentation. So the topic for my presentation today is Botox Beyond Beauty, a revolutionary treatment for chronic headaches. So I have no conflict of interest. जो हमारी presentation का aim है is to first talk about what Botox is, botulinum toxin A we'll be talking about, and the timeline of it, how it was invented or found out, and later on medical में उसका किस तरह timeline में, and especially in the use of headaches. Normally we know Botox is used mostly for cosmetic reasons, but especially in the field of pain management, it is proving its worth, and day by day with new research and everything. So this treatment modality has been incorporated in most of the chronic pain conditions. So
No,
we
no, 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 no. Am I not?
uh,
No, 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 no.
uh, Dr. Sadaf, can you please mute the mics? Okay, so basically, Botox is basically a brand name of botulinum toxin type A, which is a neurotoxic protein derived from Clostridium botulinum. And for the treatment purposes, we use a purified form in a very small controlled dose, both for the medical and the cosmetic purposes. Right now, Botox is a multi-billion-dollar medical therapy. Heavily being invested, and when compared to the medical um, uh, treatment options, it at times it's considered as the first line treatment from migraines to muscle spasticity. So if we go into the timeline of Botox in the era of 1820s to 1885, so a German physician, Justinus Kerner, was the first person who actually described botulism, and he hypothesized that its potential therapeutic uses. Later on in 1895, a Belgian bacteriologist, Emily van Armengem, he identified bacterium Clostridium botulinum as the source of this toxin. Over the period of time from 1920s to 1940s, the isolation and purification of Botox or botulinum toxin type A was done. In 1928, Dr. Hermann Sommer was the first person who basically isolated it into a purified form, and later in 1946, Dr. Edward J. Shantz and his colleagues were successful in purifying this botulinum toxin type A in a crystalline form. As an interesting fact, in 1940s, the US actually explored it to use it as a biological weapon in the 40s, but eventually they did not. Coming to the timeline of Botox in medicine, Dr. Alan B. Scott, who was an ophthalmologist, he first tested Botox to treat strabismus in animal studies. In 1980s, he did the first human trials, and by 1989, FDA approved Botox for the treatment of strabismus and blepharospasm. So here is an outline of the timeline of Botox in medicine from 1990s up till 2021. And regarding headaches, at the moment, currently, only chronic migraine has been approved by FDA, which was approved in 2010. So coming to types of headaches, as we are going to talk about uh, what headaches, we already mentioned that only chronic migraine has been approved by FDA, but these are the different types of headaches which we normally see in our practices: migraine with aura, without aura, episodic, chronic, or facial. Cervicogenic headaches are a very common sight in Pakistan. Tax the trigeminal autonomic cephalgias, which includes cluster headaches, paroxysmal hemicrania, hemicrania continua, sanct and sona, medication overuse headaches, giant cell arteritis, sinus headaches, and tension type headaches. So for this presentation, I'm going to talk about two different type of headaches for which Botox is used. One is FDA approved, one is off-label. So as we mentioned, chronic migraine headaches are FDA approved, but cervicogenic headache is currently off-label and is not yet approved by FDA. Before getting into the uh, mechanisms, or before getting into what migraine, what do we do for migraine and cervicogenic headache, we need to understand there are certain proposed mechanisms of Botox. Currently, in orofacial pain, many of the pain conditions, we do not know the exact mechanism. So it's mainly theories. And as we progress with both lab studies, human studies, and clinical studies, so we are basically day by day, we are trying to find out what the mechanisms are. But right now, the proposed mechanisms are they fall into three categories. Number one is the peripheral mechanism, which is inhibition of pain signals, is subdivided into blockade of neurotransmitter release and reduction of neurogenic inflammation. Second is the central mechanism. That means when we are talking about the higher center, the brain, in that the modulation of process. So further also subdivided into reduction of central sensitization and inhibition of cortical spreading depression. And third is the muscle relaxation and reduced peripheral sensitization, which technically means reduction in the hypertonicity in the muscles. So as we don't have much time, I'm just going to briefly go through what the mechanisms are, rather than going into an explanation that would take much more time. So the first one is the peripheral mechanism, which is basically the elimination of pain signal transmission. So normally Botox cleaves snare proteins. Snare proteins are basically involved in synaptic vesicle fusion to the membrane, which actually results in the releasing of different neurotransmitters. So once Botox cleaves it, now this vesicle cannot fuse, and thus with the help of it, it inhibits the production of CGRP, glutamate, and substance P. All three are involved in causing or maintaining pain. These neurotransmitters help in maintaining pain. So resulting, it leads to a reduction of peripheral sensitization of the trigeminal nerve endings. Second one is reduction of the neurogenic inflammation. IL-6, TNF alpha are pro-inflammatory mediators, which basically, when once released, they maintain pain. Also, Botox inhibits the mast cell degranulation and eventually resulting in plasma protein extravasation, which is basically a marker for neurogenic inflammation. Second one is the central mechanism. That means the modulation of pain from the higher centers. So number one is the reduction of central sensitization. So chronic migraine basically involves the hyperexcitability of the brainstem and the thalamic pain pathways. So what Botox does is it reduces a fast protein, which is a proto-oncogenic expression, and it's actually a marker for the neural activation in the trigeminal nucleus caudalis. So basically, in the trigeminal nucleus caudalis, it tries to halt everything so that the hyperexcitability doesn't occur. Second is the cortical spreading depression. Some evidence do suggest that Botox may inhibit CSD, which is basically a wave of neuronal depolarization, and that is one of the cause which actually causes migraine with aura. So basically, what Botox does is it increases the threshold of it and thus preventing migraine. The third one is the muscle relaxation and the reduced peripheral sensitization. So Botox normally inhibits acetylcholine release, which is a neuromuscular junction at the neuromuscular junction, which eventually results in reducing the muscle spasm and the tension and the hypertonicity of the muscles. So how does the migraine connection occur? People back in early to 1990s, when they were going through Botox, in 1992 actually Botox was approved for the cosmetic treatments. So people observed that certain, because obviously we inject it in the muscles, right, and which people who already had migraine or different types of headaches, they actually felt some kind of relief. So eventually, obviously, once a clinical trial started in 2000s, and eventually it was proven that it is helping, especially in chronic migraines. And later on in 2010, FDA finally and officially approved it because with a big large scale trials, it showed that the headache frequency reduced to 50%, and in many cases more than that. Okay, so let's narrow it down to chronic migraine. Normally, international classification of headache disorders is followed for all or different types of headaches, and uh, currently the third edition, which is ICHD3, is used. So when we look at the chronic migraine criteria, number one, it has three things in it: headache which occurs more than or equal to 15 days per month for at least 3 months. And there are further two certain criteria which it has to cover. Number one is in a patient with a history of episodic migraine with or without aura, or at least 8 days per month must meet for criteria either migraine without aura or with aura, or headache believed by the patient to be migraine and relieved by triptans or glutamine derivative, not better accounted by another ICHD3 diagnosis. So uh, there might be a question that why don't we use it for episodic migraine? Why only we use Botox for chronic? Because in episodic migraine, the the sensitization is not maintained thoroughly, so it goes on and off. Whereas in chronic migraine, the sensitization persists, the pain sensitization. So the criteria for treatment when we look for Botox in chronic migraine, number one is the ICHD3 criteria. We have to follow that. Second is if the patients who already tried like beta blockers, anticonvulsant, tricyclic antidepressants, or CGRP inhibitors, but the disease or the headache progressed. So that is so Botox is the next go-to treatment for them. Exclusions, I already explained about the episodic migraine as it lacks persistent sensitization or secondary headaches, especially if there is a tumor or any kind of inflammation or infection uh, due to something else. So migraine, the Botox treatment, we actually follow a protocol which is preempt protocol, and the full uh, name of it is phase 3 research evaluating migraine prophylaxis therapy. So patient selection criteria, number one, it has to be ICHD criteria. Number two, if we have to have certain exclusions like hypersensitivity people who are allergic to botulinum toxin, or there is any other neuromuscular disorders, for example, myasthenia gravis, ALS, uh, pregnant females or lactation category C, and if there is any infection, because we are going to inject into muscles, and there is any infection going on, we don't inject. So the injection protocol, normally the total dose is 155 to 195 units of this toxin per session. So what we do is that we dilute 200 units of vial with 4 ml of preservative-free saline, 50 units per milliliter. For needle, we use a 30 to 32 gauge or zero point 0.5 inch for superficial injections. Sorry, zero point 0.5 is for the superficial injections, and 30 to 32 gauge is normally used for the deeper injections. The total injection sites are 31, and fixed sites, that means the total units is 155. When we look at the range from 145, 155 to 195, normally optional 40 units can also be administered if extra injections or follow the pain protocol, or extra injections are needed in temporalis, occipitalis, or trapezius for localized pain as well. So if we look at the injection sites, I've already mentioned 31 in total and fixed. So the muscles which are injected are the frontalis, normally 4 sites, 2 on each side, 20 units in total. Corrugator muscle, 2 sites. We use 10 units because we are using 5 units per site. Procarius is 1 site, temporalis, we have 8 sites where we inject, occipitalis 6, and cervical paraspinalis, normally 4 sites, trapezius has 6 sites. I would, uh, uh, there is a detailed picture about it where exactly we inject. So the administration technique, we need to be careful while injecting superficially to avoid brotosis in the frontalis, corrugator, and the procerus muscles. Temporalis, we have to palpate and inject at least 1 to 2 centimeters above the zygomatic arch, right? The muscle basically tucks below the or behind the zygomatic arch, so we have to be in the muscle area. In the occipitalis muscle, the target is the belly of the muscle, and we need to make sure to avoid the greater occipital nerve, because obviously if you inject in the nerve, it's going to be a big issue. Uh, in trapezius, we inject midway between the spine and the acromion process. Here is a detailed diagram of all the areas where we inject. So the frontalis, the procerus, the corrugator, occipitalis, temporalis, trapezius, and the cervical spinal, paraspinal probe. Here is another picture of it for a better view, especially from the back, the occipitalis and the cervical paraspinalis muscle growth. So the treatment, normally when we inject Botox, it's good for 3 months. Well, actually, in literature at times it's up to 6 months as well, but 3 months is a safe bet. Normally, when we inject, it takes around 2 to 4 weeks for the onset of the effectiveness of the Botox, and the peak effect is normally attained in 4 to 6 weeks. So duration normally is 3 months, and patient is asked if the condition or the headache or the frequency is coming back, so they need to come and get it redone. When we talk about the efficacy and safety of it, so 50% or more than 50% is achieved. The common side effects, which obviously any intramuscular injection, when we ever give the patient, is pain. So normally neck pain is 9%, eyelid ptosis 4%, and muscle weakness, because definitely it's going to kind of act as a muscle relaxant as well. Contraindications, I already mentioned that if there is any infection at the site of injection, please do not give, and if the patient is allergic to Botox. So normally the post-op instructions which we give to the patient is that avoid lying down and rubbing areas for at least 4 hours. Make sure don't do any kind of heavy exercise for 24 hours, and report if dysphagia, muscle weakness, or vision changes immediately. So second condition which we are going to talk about is basically an off-label, but obviously a lot of research is being done in cervicogenic headaches. But still, at the moment, FDA has not approved it, but a lot of clinical trials are being performed, and there are certain supportive uh, studies which hopefully in future would lead to make Botox as a treatment modality for cervicogenic headache as well. So basically, cervicogenic headache is a secondary headache caused by cervical spinal dysfunction, which mainly involves the upper cervical joint C1, C2, the muscles and the nerves. So as I've already mentioned that it's still off-label, but normally when patients who have gone through physical therapy or the different nerve blocks as the first line of treatment, so Botox is being used in these patients as well with the refractory cases. Normally, the mechanisms most likely involve are the same one which I talked about. The only thing which we add is trigger points, because normally Botox is also being used as an option for the trigger points. So this almost the same proposed mechanism. Muscle relaxation, we talked about the inhibition of acetylcholine release. Pain modulation is the inhibition of the neurotransmitters CGRP, substance P. Uh, this is the one I'm talking about, the myofascial trigger point inactivation. Basically, it helps to reduce the muscle pain, which eventually leads to this headache. And modulation of the trigeminal cervical complex, we already talked about, especially in the reduction of central sensitization. The criteria is normally uh, chronic cervicogenic headache is 15 days or equal to 15 headaches, sorry, 15 headaches or more than 15 headaches per day or month. Plus, if the patients are unresponsive to the first line therapies, and patient with muscle spasm trigger points on exam. So we do a muscle examination prior to diagnosing this condition. So when we talk about the limitations, still number one, it's not FDA approved. Second is it has a very variable response. There are certain studies which favor this, and there are certain studies which say that it doesn't make any effect. So 30 to 60% efficacy has been achieved according to the literature. Again, contradictions are in patients who have allergy to Botox or any neuromuscular disorders, myasthenia gravis, etc., etc. Okay, so injection protocol is slightly uh, um, different, but in terms of the units which we give, which is 50 to 100 units across the different muscles, we kind of use the same needle, 30 to 32 gauge needle, and 1 inch for the deeper muscles, 0.5 for the shallower muscles. So the muscles which are involved is trapezius, the same as we do it in migraine, but we do sternocleidomastoid, the splenius capitis, frontalis temporalis, and suboccipitalis group. Uh, Frequency is still the same, that you do it for 3 months, and if the, you have to reassess the patient after 2 cycles. If no improvement or the patient says that it's not effective at all, immediately discontinue the use. Just to look at the target muscles, so normally we use 1 to 2 sites in the trapezius. Sternocleidomastoid is 1 to 2 sites. Sub occipital, sorry, suboccipitalis group is also 1 to 2 sites. Splenius capitis is 1 site per side, and frontalis and temporalis are 1 site per side. It is also subjective if you do find a trigger point in these muscles as well. Otherwise, if not, then you don't inject. And that is why still we don't have a proper protocol that, how many units or to give, as we have seen in the migraine patients. Risks are the same: neck weakness, especially trapezius injections, dysphagia if SCM is over-injected, and we have to be very careful with sternocleidomastoid because vagus nerve is also passing right over it. So it's always better to use ultrasound guided just to avoid injecting it into the vagus nerve. Local pain, bruising, as we expect in intramuscular injections. So if we look at the supportive clinical studies, which provides clinical evidence for Botox, uh, Frenard and Schwartz, they actually saw significant reduction in headache frequency. Lampel in 2016, he did a prospective trial of 31 patients, resulted 63% reported and 50% or greater than 50% pain reduction was there in these patients. Gobel in 2020 studied Botox, number one, with the physical therapy and with physical therapy alone. Combined therapy improved pain and function. Uh, Blumenfeld in 2010 found Botox reduced headache frequency in some cervicogenic headache patients when injected into the cervical muscle. And Rashid et al., he reported improvement in CGH with Botox targeting the myofascial trigger points. The negative or the neutral studies, Padberg, he did a randomized controlled trial of 60 patients, Botox versus placebo, got no results. Du et al. In 2018, his conclusion was insufficient evidence to support Botox. Hollander did a randomized trial and found out no benefit of Botox or placebo, and FDA status because it's still not approved. These are the other, because of the time. So I just briefly, I'm going to talk about the other headaches. Although Botox is being tried, has been tried, and is still being tried in chronic tension headaches. So the evidence is mixed. Some studies they show benefit, that it works, others they don't. Protocol is similar to migraine injections, but focus is mainly more on temporalis, occipitalis, and trapezius because these are the muscles which are involved in chronic tension headache or the areas. Hemicranic continua, if endomethacin, which is actually the go-to medication or uh, the top medication for this condition. But Botox may help. Still, they need more studies to find out. Again, similar to migraine, the injection sites, but may require a greater occipital neuron focus. Cluster is also being experimented, although still they have very weak evidence about it, but still the injection sites are sphenopalatine ganglion, SPG block, off-label, not standard. And medication overuse headaches, there is no evidence because the patient has to get himself or herself detoxed of the analgesics he or she has been using. Here are the references. Thank you very much for the kind attention. I know I have to cram it up a lot because it's a very vast topic. Thank you again.
Thank you so much, sir, for the very detailed and updated talk on the use of Botox, especially in the chronic headaches. So the house is now open for questions. All participants are requested to kindly unmute their mic and kindly share their comments and questions.
Assalamu alaikum. Dr. Hamza, it was a wonderful presentation. In fact, I joined late, so I missed the
Assalamualaikum,
initial.
sir.
Assalamu alaikum.
Ji,
In
sir.
fact, I joined late, so I missed some few slides initially.
जी
Anyway,
सर बताएं.
It was very good presentation, especially
Thank you, sir.
Botox. तो ये बताइए कि Botox जो आप आते हैं, you give it as first choice, first line of treatment, or the first you give local trial basis?
किसमें सर द chronic
Myofascial,
migraine?
myofascial में.
Myofascial is, it is basically, it can be used as a first line of medication. The only problem is it's an expensive medicine.
Yes.
So normally it depends upon the patients. We do offer them that if they want a Botox instead of a local anesthetic trigger point. So if yes, we do, and definitely we do get better results at least for 3 months or so. The patient is pain free. Normally in the normal trigger points, at times the pain goes away for weeks to a month or so, but normally we have to do a repetition of it. So yes, it can be a first line option or the first choice for trigger points as well.
Thank you.
You're welcome, sir.
और कितनी बार आपको अक्सर रिपीट करना पड़ता है Botox?
जी सर.
पेशेंट में जनरली कितनी बार आना पड़ता है आपको साल में?
Sir, normally थोड़ा सा ना it is subjective as well. जिस तरह headaches में we know कि people they do develop migraine after 3 to 4 months. But at times we have seen कि 6 महीने up till most probably like 7 8 months जो थोड़ा literature में है कि people are pain free.
जी.
तो trigger points में for myalgia.
तो हमारे पास भी हेडेक आते हैं पेशेंट काफी, तो बोटॉक्स क्रीम लगाते हैं, लेकिन इसको जिसका मल्टीपल ट्रिगर पॉइंट्स हैं और हेडेक ठीक ही नहीं हो रही, रेजिस्टेंट है टू स्टीरॉइड देम, तो जिसमें हम टेम्पोरली काफी नोटोरियस है इस मामले में.
जी सर, एक तो टेम्पोरालिस इज आल्सो नोटोरियस क्योंकि वन ऑफ द मैस्टिकेटरी मसल भी है एंड सो प्लस ये है कि जॉइंट सेल आर्थराइटिस भी उसी एरिया में
या बिल्कुल
ज़्यादा
बिल्कुल
होता है
बिल्कुल.
and that is actually unfortunately patients if they don't get medical attention they don't make it, so it's a
अरे
very.
कि मुझे किसी ने बताया था, किसी और बंदे ने, कि उनकी रूटीन रहती है कि दे टू गेट डॉपलर ऑफ द टेम्पोरल आर्टरी
जी
फॉर गिविंग
सर.
इंजेक्शन. आपका क्या ख्याल है इसमें?
सॉरी सर, आपकी थोड़ी सी आवाज सर कम हो गई थी. आप कहते टेम्परल.
टेम्पोरल आर्टरी का ना डॉपलर कराते हैं बिफोर द इंजेक्ट इन द टेम्पोरल
सर बेसिकली
आर्टराइटिस के लिए.
यू हैव टू बी, आप बेसिकली ये पूछना चाह रहे हैं ना कि उसमें टेम्पोरल आर्टरी में ना लग जाए इंजेक्शन.
ना, ना उसमें ना लगे, और दूसरा है कि उसमें जॉइंट सेल आर्टराइटिस ना हो रहा हो ना,
जी सर,
वो भी
बिकॉज
हेडेक हो रहा हो.
नॉर्मली थोड़ा सा पेशेंट की हिस्ट्री भी होती है एंड यू नीड टू सी द पल्सेटिंग आर्टरी. अगर तो आपको फील हो रही है ना, सो इट्स ऑलवेज बेटर टू हैव द पेशेंट को एक मेडिकल कंसेंट करवा दें जस्ट टू बी ऑन द
या
नॉर्मली.
उसके साइड पे चले जाएं, तो उसको उसको साइड टच उसके करीब ना जाए, उसके करीब ना जाए, बस यही है.
जी सर, और दूसरा ये होता है कि वी डू ट्राई टू पैल्पेट कि कहीं आर्टरी अगर हमें फील होती है तो जस्ट गो अराउंड द आर्टरी.
हाँ
Normally,
बिल्कुल
I
बिल्कुल.
when I do ये greater occipital or lesser occipital, so that the वो जो उसका सर एक फॉर्मूला है ना, फिंगर्स रख के and then
या
you give a blind shot. So बस वो कुछ होता है कि आप अल्लाह तवक्कुल भी दे देते हैं कि लग जाए बस सही जगह पे. But I guess अगर if we do get trained while doing ultrasound guided, it would be a great thing.
यस यस.
कम से कम at least we can visualize के where we are entering.
दूसरा जो मैंने देखा ना अपने प्रैक्टिस में, कि टेम्पोरली, सॉरी, ट्रेपीजियस भी बड़ा नोटोरियस है.
जी सर, बिकॉज normally when we are giving we are blind, so वो आप pincer movement पे you pick up the muscle and try to inject, but obviously you know because we have to do a little fanning for the
या
back and forth, वो needling करनी होती है. concept तो सर basically needling है. अगर
जी
if
हाँ बिल्कुल.
doing needling, so that helps. इसलिए I think the best thing is now the lasers. Photobiomodulation is the next thing to do. So it is less invasive compared to actually when you are inserting a needle in the patient.
Thank you.
Yes, you're welcome, sir.
Thank you so much, sir. Sir,
You're welcome.
did
जी
you
जी.
ever come across any serious complication after giving the Botox injection in your personal clinical practice?
Actually, I have given it in US. Pakistan में अभी तक नहीं दिया, but thankfully अभी तक no. And I haven't heard among my colleagues and peers के कोई इस तरह का issue आया हो. But obviously, you have to take a very detailed history. You need to know the patient inside out when you are giving it. Uh, so make sure that there is no such medical condition which is going to be a contraindication for it.
Thank you so much, sir. So we have some more questions from the
जी जी
participants.
जी जी.
They're in the chat box, so
Uh,
I'll read it for you. Yes, sir.
हाँ जी.
Uh, Kindly elaborate how many injections in your practice are needed for chronic migraine to completely disappear.
अच्छा,
Pain in this
इस
session.
इसमें नॉर्मली जो है ना वो 31 साइट्स को हमने करना होता है जी. फ्रंटालिस है, कॉरिगेटर है. मैं ना लेट मी जस्ट पुल अप माय I don't know if I can pull up the slide. Sorry, एक मिनट जी. Let me pull up the slide. So basically, अगर if मेरी पावर पॉइंट आ रही है जी नजर.
Yes, sir. We can see your
हाँ जी.
screen.
So basically these are the muscles which we inject. Frontalis को करते हैं, ठीक है जी. Corrugator को करते हैं, प्रोस्ट्रियस को करते हैं, टेम्पोरालिस है, ऑक्सीपिटालिस है, सर्वाइकल स्पाइनलिस, पैरास्पाइनल्स एंड ट्रेपेजियस. सो द टोटल ऑफ 31 जो है ना जी साइट्स होती हैं जहाँ पे वी गिव, एंड वी हैव टू
Oh,
गिव इट इन यूनिट्स.
okay. Probably the participant wanted to ask the number of injections that you repeat frequently, like after a month or two
ओके, सो
months, or
बेसिकली नॉर्मली जो माइग्रेन, क्रॉनिक माइग्रेन है, literature says 3 months, and 3 months में patient they do have a good reduction in the headache. होता ये है कि normally we have seen कि the span stretches from 3 to up till 6 months. At times patients are pain free या their headache has gone so low on the VAS scale that वो कहते हैं कि we can. हाँ, but ये होता है कि fourth, fifth month में you might need to repeat the injection. सो होता ही है कि एक द टर्मिनोलॉजी नॉट, मतलब इट्स काइंड ऑफ अ लेमैन टर्म हम यूज करते हैं. जो ट्रिगर पॉइंट्स होते हैं या मसल इंजेक्शंस होते हैं वो हम अपनी जुबान में कहते हैं वी काइंड ऑफ जंप स्टार्ट द ब्रेन अगेन. सो वो एक है. एंड द ओनली इशू इज कि वी स्टिल डोंट नो ऑल द मैकेनिज्म. सो एक थ्योरेटिकल चीज पे वी डू फॉलो एंड रिसर्च होती है. तो वंस आई होपफुली इफ लेटर ऑन इन लाइफ अगर एग्जैक्ट मैकेनिज्म पता चल जाए. इनफैक्ट कुछ देर इज अ न्यू मेडिकेशन, इट्स वन ऑफ द मैब्स, ये जो मोस्ट प्रोबेबली आप देते हैं फॉर नॉट एग्जैक्टली अ कीमोथेरेपिक एजेंट, बट 6 महीने जो है ना, द पेशेंट इज पेन फ्री. सो यस, other than Botox, we do have other treatment modalities as well.
Thank you, sir. Sir, our next question is which objective criteria or outcome measures do you recommend for monitoring therapeutic response over repeated Botox cycles? And given the cost of the treatment, how do you justify or prioritize Botox in low resource or public healthcare settings?
देखें, द थिंग इज, क्योंकि ना मैं अभी करंटली आई एम नॉट, आई हैवंट डन बोटॉक्स इन पाकिस्तान बिकॉज नंबर वन आई डोंट हैव अ प्लेस टू स्टोर इट. सो यस, इट इज एन एक्सपेंसिव ऑप्शन, and majority of the patients, because it's very subjective. कुछ अमीर लोग भी आते हैं and they are like, we don't want to spend this much amount of money. So normally ये होता है कि we do have a follow up as well, कि patient को हम कहते हैं कि let us know. The problem I've seen in Pakistan is follow-ups are not that good. And either दो चीज़ें होती हैं, या तो the patient was totally fine, totally pain free, तो he or she would not contact you unless and until वो दोबारा होता है. या फिर ये होता है कि द ट्रीटमेंट डिडंट वर्क एंड द पेशेंट वेंट शॉपिंग फॉर सम अदर डॉक्टर्स. सो दैट इज व्हाट द प्रॉब्लम है. इसके एक तो फॉलो अप हो तो एटलीस्ट यू नो कि यू हैव आप कह लें जिस तरह कैंसर रजिस्ट्री होती है, आपके पास एक पेन रजिस्ट्री भी बन जाती है, एंड यू नो कि जी हमारी पॉपुलेशन में हाउ मेनी पीपल आर गेटिंग गुड रिजल्ट्स. बिकॉज currently you would agree कि orofacial pain and pain management has gone to the genetic level. So genetically now things are being seen ताकि because every race have different genetic makeover. Certain conditions या हमारी region में are more common. If you go in the west or US, वहाँ पे आपको different मिलती हैं चीजें. So I guess एक follow up हो तो that would be much better. एंड बट जो लिटरेचर में हमने देखा है कि पेशेंट्स आर नॉर्मली दे डू रिस्पॉन्ड वेल टू इट.
Thank you so much, sir. Dr. Shahid wants to know the role of acupuncture. I think this is beyond this topic, but if you want to
हाँ बेसिकली
give any comment on it.
जी 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 बिल्कुल. सो ऑक्यूपंक्चर इज इफेक्टिव. वन ऑफ माय colleagues, she is from India, Dr. Ruchika Sood, and she did her OFP and then she came back to India and she did acupuncture. And मैं उनसे पूछ रहा था कि and she said कि इट इज़ वेरी रेलेवेंट. जिस तरह डॉक्टर खालिद साहब सर से भी बात हो रही थी कि बेसिकली द कॉन्सेप्ट इज नीडलिंग इन ट्रिगर पॉइंट्स. you hit the right spot. हम even if you give saline instead of uh, anesthesia or Botox, but you have hit the right spot, it will help. So acupuncture definitely literature में है कि it helps and it is an ancient treatment as well. Although ये है कि basically अब वो थोड़ा बहुत जो है कि even the allopathic people like us जो इस स्कूल ऑफ थॉट को पहले वी यूज टू लाइक ऑल्टरनेटिव मेडिसिन को हम लोग साइड बेस कर देते थे, बट यस उसकी रेलेवेंस है एंड डेफिनेटली it does produce good effects.
Thank you, sir.
जी
Do we have any other comment or question from the audience?
जी सदफ डॉक्टर अतीक बात कर रहा हूँ.
जी
थैंक यू
अस्सलाम
हमजा.
वालेकुम. जी
Hamza,
अस्सलाम
just want to
वालेकुम.
add on the something rare about the Botox.
जी
So
सर.
one thing to remember, like for the trainees, there is a very rare side effect of the Botox that you can develop the autoantibodies. So the
एग्जैक्ट.
patients who are coming for the repeated session, sometimes you notice like you are doing a second session, and the patient hasn't got the same response as he got with the first one. So that may indicate the patient had developed the antibodies there. Just to keep in your mind, like that's the one thing. And the other thing, other than the headaches stuff, I know in the chronic pain it's very popular for the headache, but there are other areas that where we are using the Botox. One of them is the failed back surgery syndrome, where the routine like facet joints or the epidurals or transforaminals are not working. So people are trying
बिल्कुल.
the Botox in the paraspinal muscle. So that's another interesting area. And the other thing, I think so most of the people most of the guys you know about it. The one is the spasticity secondary to the cerebral palsy. The
जी
arthropods
सर.
do the Botox there. So just in the cost, like regarding the cost, we have been talking a lot about the cost. So in Pakistan, there are two types of the injections available. One like typically Botox, that's the US made, and the second being imported as well. I think so it's a Korean make. Korean one is a little cheap. So and US one is a little expensive. Uh, but keeping in mind like the people actually who need it, it doesn't really means 30 40,000 keeping the cost of the medications and the days of the disability they're gonna mean out of the job. It's not really the huge in private sector particularly. I think so we should be as a pain physician doing it more and more and having, as you said, mention like the local registry and the local data. Thank you.
जी सर, मैं जस्ट वांटेड टू ऐड वन थिंग क्योंकि सर नॉर्मली वो डिमांड एंड सप्लाई की बात होती है ना. सो मोर पीपल स्टार्ट गेटिंग इट डन तो वो ऑब्वियसली फिर आपको और भी ब्रांड्स आते हैं. सेकेंड ऑफ ऑल इट हैज टू बी ड्रैप अप्रूव्ड एज वेल. क्योंकि खुदा ना खास्ता if something goes south then वो आप liability बहुत बड़ी होती है, क्योंकि in our field I know pain is something which is a very complex thing. It's a very difficult, I would say at times it becomes a difficult task to treat patients. And currently right now अगर orofacial pain in US, we tell the patients, normally पाकिस्तान में हम कम बताते हैं, but 40% भी अगर reduction होगी, that is a clinical success for us. Any other questions जी?
ये बड़ी अच्छी हमारी डिस्कशन हुई है, वेरी गुड, वेरी हेल्दी
जी
डिस्कशन
सर.
हुई है, बड़ी अच्छी डिस्कशन हुई हमारी, इट वाज गुड.
जी सर. नहीं, थैंक यू वेरी मच सर, बल्कि मज़ा आया काफ़ी.
थैंक यू फॉर योर टाइम, बहुत शुक्रिया आपका.
वेलकम सर.
जी.
So, thank you so much, Dr. Hamza, for joining us. I think we don't have
Welcome.
any other comment or questions from the audience. Thank you everyone for joining us, and thank you, Dr. Hamza, for
You're welcome
it's a
जी.
great honor to be here, part of this activity.
Yeah.
Thank you so much.
You're
That's
welcome
all
जी.
from my side.
Okay जी. Thank you.